the 4th. After that, there will be a call within a week and probably within a day or two to go over all the requirements as well as the ask for ORHP. On a second note, the measures that will be included in there are the measures that we are putting forward to OMB for approval for PIMS collection. The PIMS collection will begin on 9/1. You'll have 60 days. We listened to what everyone stated about PIMS previously, and we are in the middle of changing how we collect that information. We are trying to work on the user interface and to make it a little more user-friendly to drive the actual burden down on all of y'all. So ideally, we'll have that available for 9/1, as well as the measures that we are going to request you to collect. Those measures that are going forward to OMB are basically the same things you've been doing for last year. If anything, those measures, you will have these measures to report because you will have to have done steps to get to the measures that you have been already gathering. So it shouldn't be an additional burden on finding additional information. It should just be a step in the process. Other than that, as a reminder, SHIP and Flex are really integrated, and the SHIP numbers, the SHIP competitive guidance has actually moved things forward with MBQIP, so there are more CAWs participating in MBQIP because of the SHIP guidance. Keep in mind that MBQIP is mandatory under SHIP, and that is the direction we'll be moving with Flex when it comes to that type of activity. MBQIP is something that we're trying to work with and to advance our topics. It's voluntary currently under Flex, but it is not voluntary under SHIP. So be sure to understand the delineation. Additionally, we are trying to communicate both on the Flex and SHIP sides of things, because some Flex coordinators are the SHIP coordinators and some are not. Some offices have separate positions there. So not everyone will be receiving the same emails. Keep that in mind. Some of them are SHIP specific. I can only encourage you to communicate within your offices regarding what messages are coming out, to make sure that if there is a message of interest to Flex, that your SHIP coordinators share that with you. With that, I will hand it off to Michelle for her policy update, and hopefully there's no echo.
A reminder, Michelle, that it's *# to unmute your line.
Hi, sorry, I was having some trouble with my phone. Hopefully there's not an echo on my phone as well. I'll try to be brief on this. So just wanted to let you know that there are a few different regulatory issues that I wanted to let folks know about. The first one is last week CMS released a new regulatory burden reduction rule that proposes to make changes to the conditions of participation or conditions of coverage for hospitals, rural health clinics, federally qualified health centers, and for critical access hospitals. These are the conditions that healthcare organizations have to meet in order to begin or to continue participating in Medicare. CMS is asking for public comment on these proposed regulations, and it's really, really important that rural providers and stakeholders share their concerns and their comments with CMS. So what is it that you can do as a SOAR or a Flex program coordinator? You really should read these regulations. Surprisingly, they're very short. They're only about 31 pages, and the rule sections is a lot shorter. It's like 4 or 5 pages to read. Share the rule and any of the proposed changes with your critical access hospitals and rural health clinics that you work with. And if you're so inclined, submit comments. On the slide that I have up, you will have links to where you can go ahead and submit the comments and also where to find the rule. For those of you that are so inclined, I have about 3 slides here that you can read at your leisure that goes into more detail about the regulatory changes that they are proposing. Now, a little bit of information about the health insurance marketplaces. This is what used to be known as the health insurance exchanges. The most up-to-date information can be found at these 2 email addresses that I've listed on the slide. I really recommend that you go and look at these websites, get familiar with the data and the information that is on these websites. This is on the next slide, there's a map that shows from Kaiser Family Foundation that shows what the decisions are for states so far as of yesterday, if they're going to be participating in a state-run marketplace, a federal marketplace, or if they're going to be doing a partnership, a state and federal partnership. So you can look at that map and find your state and see what is being proposed. One regulatory issue that I wanted to briefly touch bases with you about is the guidance that CMS released late last month on essential community providers. So why is this important? The essential community providers include all providers that are approved to participate in a 340B drug pricing program. So this does include critical access hospitals and sole community hospitals. The Affordable Care Act does require that all insurance plans that are offered through the health insurance marketplaces, otherwise known as qualified health plans, have to include these essential community providers in their provider network. It does not require that these plans contract with all of those essential community providers in their area. They just have to have a sufficient number and geographic distribution of these providers where available to ensure that there is reasonable and timely access to broad range of these essential community providers. So it's really important that the critical access hospitals that you work with and other rural providers like rural health clinics that may not be considered essential community providers that want to be included in these new provider networks be working now to establish these contracts with these new health insurance plans. Open enrollment for these qualified health plans through the marketplaces begins October 2013. Oops, wrong way. So what is it that you can do as a FLEX coordinator or as a state office of rural health? First of all, I really encourage everybody to go to the website that I've listed here on the slide for all of the information that you can, that there's brochures, there's webinars, there's a resource toolkit, and in multiple languages as well, so that you can get familiar with what's going on at the federal level. Then find out if your state is planning to run a federal, a state, or partnership exchange. You can look at the Kaiser Family Foundation website. We really encourage you to contact your state exchange coordinators in those states that are operating their own exchanges or marketplaces, or the insurance commissioners in states with the federal-run marketplaces to find out what plans are seeking to become these qualified health plans. Talk to those plans if you can. Talk to those plans. Talk to the state insurance officials and really help educate them about the important role that your providers, your critical access hospitals that you work with, any rural health clinics that you work with, to make sure that they know that these are essential partners in providing care to rural communities. This is especially important for those that have state-run exchanges, as they will be setting their own standards on what they consider appropriate. And also talk to your rural providers that you work with. See if they're being contacted now by those qualified health plans to begin contracting with them. If they haven't, it might be good to give them information about what are those plans that are looking to to become part of the exchanges. If they have if they have already started contracting, then that's great. The last thing that I also did provide a slide with a lot more of the regulatory information if you would like to take a look at that later on. The last thing I wanted to talk about is just a reminder about the supervision of outpatient therapeutic services in CAHs. So CMS will not enforce the supervision requirements for the outpatient therapeutic services in critical access hospitals and certain rural hospitals for calendar year 2013. They have indicated that this would be the last year that they do have this notice of non-enforcement. There is a current list of all the hospital outpatient therapeutic services that can be currently furnished under general supervision, and I provide a link on this slide. If you have any questions on any of this information, of the stuff that's in this presentation, feel free to contact any one of us on the policy team, contact myself, and I'm not sure if there would be any time for questions or not, but feel free to email me your questions, and this is all of my information.
We can take a question or two if folks have any direct question for Michelle.
If you do have questions for Michelle, please remember to press *# on your telephone keypad to unmute your line.
And if you don't have questions now, do feel free, as Michelle suggested, to contact her with the kind of follow-up questions. Thanks.
I have a question.
Sure.
This is Jill from Arizona, and so from my understanding, we're supposed to be connecting with our cause to get their contracts in place with the new exchanges?
Oh, no. You don't have to be working to make sure that they have those contracts. It's just good for them to know that, these qualified health plans are going to be providing are going to have new people that are going to be insured in their communities. So they might want to start contracting with these new health insurance plans if they aren't already. So it's more of an information sharing for your critical access hospitals. Let them know that these qualified health plans are going to start providing services, are going to start insuring people in that community. Does that answer your question? You're not necessarily helping them with the contracts, although if you have that expertise in-house, it's wonderful.
Okay. Thank you.
And I just want to add on to what Michelle said. In essence, so many of our hospital boards really don't understand what's going on. So a big part of our FLEX program, it seems to me, as we move forward here, is to get useful, understandable information to these critical access hospitals so that they can make informed choices in the future. Such. And we'll help, TASC will help in any way we can in that translation and that public or that hospital information as well.
Well, thank you very much, Michelle and Mike, for those updates. We have John Gale on the line from the University of Southern Maine. And John, if you're available to provide an update from the FLEX monitoring team.
I'm here.
Great, thank you.
Right. Well, I'd just like to actually give you a very brief update on a few things that are going on with the FLEX monitoring team. We have a series of projects that are underway now that some of you may be interested in, looking at issues related to outpatient indicators for the Critical Access Hospital Financial Indicators Report. The Minnesota folks are still looking at quality issues related to medication safety strategies and measures for CAHs. We're this year actually doing a couple of projects. One is really looking at the correlates of community benefits and the range of community benefit activities across CAHs and in comparison to rural and other rural and urban hospitals, using which we think we're excited about is the 990 data from the IRS. So that'll be rolling out sometime before June or July. And finally, the last big one that we're working with is the project related to community paramedicine. So we're contacting all the EMS agencies across the country, all 50 states, to get a read on what they know or may be doing related to community paramedicine, and we're working then with those states and examples of programs on the ground. You've probably heard from some of our staff who are arranging meetings with state office and flex coordinators who are engaged, and we've done 3 or 4 calls already. So that will be done hopefully sometime by April, the data collection by April, and a report out by May or June. So they're the big projects that we're all working with, and we're all still staying with very closely to our scope of work related to community impact and benefits, hospital financial performance, and quality. The one thing I think it's important for you to know and that we're working on is a process to make our materials and reports more useful to the states and to hospitals. We're exploring the development of a unified reporting system that would have all 3 sets of measures that each of the 3 centers are engaged in. So that is underway now, and we will probably go to our key stakeholders, not only within the office, but within TASC and the state offices and flex programs for some input on that process. But I think that from our perspective, we've been looking to repackage and make that information a bit more useful and user-friendly to the states. And that's really a quick update on where we are. We've just gone through a competitive application cycle for the monitoring team cooperative agreement. That was done and submitted for the next cycle. And we also remain, if there's any new flex coordinators on the phone, available to provide any assistance and support that we can. We work very closely with many folks from NOSOR, the state offices, and the flex programs around technical assistance and to share information. So I'd encourage you to use us as a resource. And I think that's it, unless there are any questions.
Terrific, John. Earlier today, our TASC Advisory Committee met, and we heard from Dr. Ira Moscovici about kind of the new suggested directions, should you guys be funded, and that is the integration of the quality, the financial, and the community data. Really seems like an important step forward. And I heard you say pretty much the same thing. Is that correct?
Yes, that's exactly correct. And one of the things that we will be doing in that process, once we've developed the framework and looked at the indicators, and this will probably be an evolutionary process, we'll want feedback from the users of our materials to really fine-tune that process. So you will be hearing from us on that as that project progresses.
And one of the reasons we discussed this morning that this is very important is that as we're moving into a value-based healthcare system, those are the dimensions that are going to be absolutely necessary for critical access hospitals to demonstrate. It'll be about quality, it'll be about cost, and it'll be about population health in the community itself. So again, I think that's just a really good project if it's funded, et cetera, and I think it's going to be very helpful for our flex programs and for our hospitals as well.
Well, and actually this year we're exploring, we're working on the development of a prototype for that report. So hopefully, if we're refunded, that'll go forward. But we will be working between now and August, when the current cycle ends, to develop a mock-up of a report and data elements. So this is moving ahead pretty quickly.
Great. Thank you, John.
You're welcome.
Just a few other updates, and then we'll move into the topic of the day. The National Rural HIT Coalition has a broadband subgroup, and last week during the National Rural Health Association's Policy Institute, the National Rural HIT Coalition held a broadband summit, really focused on bringing together national, federal, local level stakeholders representing both the public and the private sector to talk about moving rural broadband adoption and integration out across the country. And so we had a great meeting with panels representing both private and public sector, as I mentioned, and then small group work, really working on developing recommendations that can be put hopefully into place. So coming from that will be a white paper, and we anticipate releasing that within the next month or two. So look for more information coming about that, and really some messages about not only that broadband is really needed to implement health information technology effectively and to achieve meaningful use, but really also to keep rural America working well with urban centers as well through things like telemedicine and keeping the population within the rural communities that they do call home. So it was an exciting meeting and much more to come from that. TASC is currently updating the Flex Coordinator Manual for the 2013 version, and we anticipate releasing that to you in early March along with when the Flex Grant guidance will come out. We're also finalizing the much anticipated evaluation toolkit for the state Flex programs. We anticipate finalizing that this month, and we'll be hosting a webinar too to launch that toolkit. The date for that is not yet set, but look for more information to come on that very soon. Just a reminder, there is a virtual knowledge group call on Friday, February 22nd from 1 to 2 p.m., and that will be for the group on balancing the Flex coordinator role. Any Flex program personnel is invited to participate in that discussion, and Kate Stenyon will be sending out a reminder about that call, again on Friday the 22nd. TASC staff will actually be reaching out to each of the state Flex programs within the next few weeks here at the end of the month. And what we'll be doing is looking to talk to you as a follow-up to the activity that you submitted this summer with the Flex Conference. So we all completed a blue worksheet at the Flex Conference, picking a lesson learned or best practice for the conference, and then developing some activities and measures to move that, that activity forward. And so we'll be giving you a call just to find out where you are with that, if it's happened, if it hasn't, what your challenges and roadblocks might have been, what successes you might have had, and just compiling that information then to share with ORHP. So we'll be looking forward to actually talking with each of you, and it'll just be a great chance to catch up too. As Mike mentioned earlier, that Flex and SHIP are becoming much more integrated. The National Rural Health Resource Center has been assisting the Office of Rural Health Policy in hosting a series of webinars on SHIP. There will be 3 webinars for state-level SHIP grantees and 4 webinars for SHIP-eligible hospitals. I know there's been some confusion because those messages have been coming out through TASC, but they haven't been going to all Flex coordinators. They've been going to whoever is designated as the SHIP coordinator within your state, and so that's why some of you might not be receiving messages even though it's coming from a group that you're familiar with working with TASC. But do know that those webinars are all being recorded. So even though they might be targeted to the SHIP coordinator or to a SHIP hospital, they're recorded and available then for playback. And we'll be sending out more information about those available recordings as they happen. There'll also be a series of 4 manuals to accompany some of those webinars as well. And then I just wanted to ask Terry to talk a little bit about some work that we have planned for this spring in a small group meeting.
Thanks, Tracy. Basically kind of building on the summit meetings that we've been holding over the years, several on the area of quality improvement for critical access hospitals. This past June, a financial summit meeting, and hopefully you've all received copies of the CAH Finance 101, as well as the outcomes, the identification of kind of key financial indicators that our group decided were generally going to be the most important. We intend to put out another manual later this program year. That's going to be kind of a culmination of what have we learned over the years about how to drive sustainable performance in critical access hospitals. It'll incorporate the pieces that we've learned about finance. It'll include the research that's done by FMT and other research organizations. It will basically talk about how to coordinate and how to manage the various initiatives within a hospital. As you know, we've got health information technology, ICD-10, the RAC audits, et cetera, et cetera. So much stuff, in fact, that so many hospitals, or at least the ones we hear about, are confused, they're overwhelmed, et cetera. And so we're going to suggest a blueprint based on what we know about the high achievers, kind of what has been important, key factors within a number of different frameworks. We're going to use the Baldrige framework. That I want to be clear about this. We're not going to mandate or suggest that hospitals do Baldrige necessarily, but simply use that framework because it was the one that was recommended in our Quality Summit meeting a little over a year ago. And so we're going to organize the information and the indicators under Baldrige, and you'll get a chance to respond. Some of you are going to be enlisted to help us, and you're going to get a chance to kind of respond to it in draft form this summer when we meet in Bethesda, Maryland for our annual meeting. The feedback will then be incorporated into this document, and the thought is to have it available by the end of the year, program year. We're doing this in full coordination with ORHP and with Mike McNeely, and we're hoping this is going to be valuable. It's designed to be understandable by the hospitals, relatively simple to use, et cetera. And we're not trying to duplicate what the researchers are doing, rather supplement their work and suggest kind of a formula or some sort of a blueprint about how critical access hospitals might move forward based upon their experiences and what we know about the really successful ones that are out there. Great.
Great. Thanks, Terry. With that said, and talking about frameworks, that's a good segue into the topic today. So we know the Flex Grant guidance is coming out soon, and we realize too that over the last year or two, there's been a lot of changes that have happened with the Flex Grant guidance. More emphasis placed on strategic planning, continuing to update the Rural Health Work Plans, documenting outcomes, and thinking about measures in a different way than before, continuing activities from year to year. And so we thought we'd try something different with the TASC 90 today and hold a facilitated discussion with the Flex programs about developing a good state Flex program work plan. So that's our topic for today. There's a million things we could talk about with this, but we kind of narrowed it down to maybe 3 key items with some input from Mike. The first thing we'll talk about is the importance and value of a framework. Then we'll move into a discussion about documenting measurable outcomes. And then lastly, we'll close with a short discussion about multi-year activities and thinking beyond a one-year budget. So with that, Terry's going to lead us off with first some introductory information and then a discussion about the importance and value of a framework.
Okay, thanks, Tracy. What you see on your screen now is the result of no plan, no framework, et cetera. We've been using several frameworks here at the center. The balanced scorecard for the last, I think it's 8 years, and now we're adopting a Baldrige framework to kind of capture the resources, the information, et cetera, that we need and that we want to make available to the Flex programs and ultimately the hospitals as well. Some of you may be familiar with Dr. Atul Gawande, and if you're not, I urge you to either read his books. Checklist Manifesto, for example, was one of our book club books. He's also written another book, which is going to be on I think, one of our next book club selection list, which is talking about better. And he's become kind of a spokesperson for a lot of the reform movement that is taking place, the changes that are coming down, et cetera. And he does a YouTube video that I've seen as he discusses walking back to his hospital after, I don't know where he was in the park or whatever, and he noticed that they were building a large medical office building adjacent to the hospital. And he went in, he started talking to people, and he thought, here's this very complicated building that's coming up. I wonder how these folks are coordinating their activities and he started to equate it to how the hospital was run. What he discovered is there was a master plan in place, as you might expect, and there was a finite timeline, and the people that were putting in the plumbing were in full communication with the people doing the electricity and the builders, et cetera, et cetera. And he took a look at his hospital, and this is one of the better hospitals on the East Coast, and he said, we have nothing like that. We have no blueprint. We have no plan moving forward. And what he has said is that making systems work is the greatest task of our generation as a whole, not just healthcare, but redesigning the systems in such a way that we're going to be managing the increasing complexity kind of moving forward. So in essence, we would recommend from TASC and from some of our states here that have used them, the uses of frameworks to ensure a systems approach and to ensure that you're kind of managing the complexity both of the FLEX program and of the critical access hospitals. Our immediate plan is to develop something using a framework for the critical access hospitals, but I guess we're encouraging you to think about using a framework as you put your grant application together, as you look at the future of your program, et cetera, and we're going to talk a little bit about how those look. So what you see there is a blueprint that in essence it's a plan kind of moving forward. And I'm just briefly going to mention three quick ones. Again, we've got depth of knowledge in all three of these, and we're also going to have some FLEX folks talking about these as well, but I just want to go over them very briefly. This is Baldrige, and Baldrige is the gold standard throughout the United States and probably throughout the world about how to achieve sustainable outcomes at the back end of the system. It starts with leadership. It's about strategic planning, focus on patients, workforce, process management, and measurement analysis, and knowledge management. Hospitals recently have been winning the Baldrige Award itself, but most of those have all been urban-based. Our thought here is that this framework really makes sense for the FLEX program because it's always about the leadership. It's so important in terms of the strategic planning. There's going to be a huge emphasis on community health and working with the community, et cetera. In process management, we get into lean, et cetera, and I'm going to have some other folks talk about this in a minute. A second piece is the balance scorecard, and what you see there is one of our balance scorecards, which really is a formula. We call it the formula for center excellence, and it talks about our investment in staff and in change-ready culture and maximizing our web and information technology, which is under learning and growth. It talks about internal processes, and we're trying to get out what you see in terms of the marketing sales is more about the fact that we want people to know that we have a lot of resources available and that they can use them. It's really not, for us as a nonprofit, about making money. We're on a constant improvement cycle, and we also have, now each one of those strategies as they're put out there have drilled down actions that are there and activities involved as well. Those of you that are using Balanced Scorecard, I think, can relate to that. And then basically it's a systematic way of managing what we do here at the center. We have both an overall center Balanced Scorecard and we also have a task Balanced Scorecard that we use. I can tell you that our board loves it. It has been incredibly important for us as we're moving forward. Tracy's going to talk about the logic model.
So, and the logic model really can be used to show how a program should work. It presents planned activities for the program, and it really focuses on anticipated outcomes. So it uses diagrams or pictures that illustrate the logical relationship among key program elements through a sequence of if-then statements that are often used, in the logic model framework then. And while they present a theory about expected program outcome, the logic model does not demonstrate whether a program has caused observed outcomes. So there's some simple reasons for using logic models, and that's because they can really lead to more successful programs by providing a planning tool, just like any of the other tools we were actually just talking about, providing an opportunity to describe intended outcomes, monitoring program progress, and identifying potential questions for evaluation. So as the slide here depicts, as you move from the left side of the screen from inputs of where we actually invest our resources and money and funding and personnel time to outputs of what we want to do, the activities, and who we want to reach, our participants, then we move from there over to documenting the results in short, medium, and long-term outcomes. That's just a really high overview of Logic Model. We have some other resources available on Logic Model. The evaluation toolkit coming out, we'll talk about that as well. We even have some past webinars that John Gale, for example, has provided. So just a quick overview there of some potential frameworks you can think about using in the FLEX program. So what we're going to do now is move into a short discussion about examples of using those described frameworks in the FLEX program. So we've kind of asked some of the FLEX people on the call to be prepared to engage in a discussion, and we also would love to hear from others on the call too. But Dave Palm, the director of the Office of Rural Health in Nebraska, has been using the Baldrige model. And then John Ike, the director of the Wisconsin Office of Rural Health, has been using the Logic model and balanced scorecard. So Terry's going to walk through some questions now with Dave and John about why they chose to use the particular frameworks that they are, benefits, challenges, and other things like that.
Dave, why don't we start with you? I know that you've used a Baldrige framework to kind of as kind of an overview of your program itself. Could you begin by telling us why you chose it and kind of how it's worked? And it's *# to unmute your line. Well, we're not hearing Dave at the moment. John, let's turn to you and hello.
Oh, sorry. This is Dave.
Oh, okay, Dave.
I apologize.
No problem.
No, in terms of the Baldrige model, we were first attracted to it because, as you said, it started with leadership and kind of ended with results, but there's a big focus on measurable results. And as we were beginning to think about adding programs and activities, such as the balanced scorecard for hospitals, such as lean management, team steps, and leadership classes and so on, that we felt we needed some kind of framework to really think about where we were going and how all of these activities fit into our FLEX program. So we observed that, especially that hospitals that have been successful always had good leadership. Doesn't always ensure success, but we haven't found very many hospitals that have been successful in quality and financially without good leadership. So that was one of the big attractions for us, was to think about how we could put everything into a framework or a blueprint as you've described. We only use the Baldrige model. We are a big supporter of the balanced scorecard for hospitals, and we continue to provide those activities and technical assistance to hospitals. So but I might point out that many of the elements of the Baldrige model are very similar to the balanced scorecard. Obviously the balanced scorecard is related to strategic planning. It has a workforce focus. It has process focus and so on. So there are many similarities. In terms of benefits, I think that the biggest benefit for us was really to think about how we can measure our results. And that's not always easy to do, and we haven't always been totally successful in doing that. Oftentimes, there are more process measures than real outcome measures. But I think that has been a great benefit for us. And so we try to always think up front, how are we going to know when we are successful at the end? So that's been, I think, one of the major benefits for us. In terms of challenges, I first presented this Baldrige model to we have a QI steering committee, about 15 to 20 people, mostly QI coordinators, some hospital administrators, and they sort of looked at me like I was somewhat crazy here. I think we've overcome that, but it's not necessarily intuitive right away to everyone that you're working with, and so you have to have some experience with it, and I think be able to apply it, show people how you're using it. By just showing them a model, we got a lot of different reactions to it. So I think all in all, the Baldrige model has been very good for us. It's given us direction. It's really helped us think about ways to fill the gaps, to support hospitals and provide technical assistance, and hopefully measure our results along the way.
And so, David, one of the things that I heard you say is that you're using both. So it isn't an either-or state, and in fact, that's the same thing we do at the center. If you look at the Baldrige framework, which is up on our screen now, the balanced scorecard can be used in number 4, measurement analysis and knowledge management. It provides a really nice way of kind of monitoring what's going on within the program. We also use the strategy map, which is part of balanced scorecard technology, to do some of our strategic planning as well. So, and then I also heard you mention lean, because lean fits into number 6 perfectly. It's just like, yeah, we have to do process management as well. Now, what I'd suggest, and I think what I heard you saying, is that this takes a holistic approach to really what needs to be done within an organization. And, I guess I challenge anybody to think, which one of those could we leave off at this particular point? It's, workforce is so important. The efficiencies that you get with better process improvement and 6 is so important. Certainly we couldn't leave off 3 because, everything's going to be about the patients and the community health, et cetera. And I agree with you. The reason I was attracted to this model was partially because it starts with leadership, and there's no more important component we could be talking about.
Yeah, I certainly agree, Terry, and I think that, of course, flex programs have evolved over the years, but when we first started using this model, we had, and still do, but we had a lot of weaknesses in many of these areas, and so we're trying to sort of fill out the model, fill out the framework, and I think that that's helped us, as I mentioned earlier, to identify some areas that maybe we wouldn't have gotten into had we not used this model.
Thanks, David. John Ike has been using particularly the logic model. We wanted John to kind of focus on that, but I believe he's also using balanced scorecard as well. So John, can we ask you some of the same questions we just asked Dave about why you chose this model and what the benefit has been?
Sure. So I would say, the logic model has been pretty well reinforced by the FLEX program. It's to some degree how the FLEX work plan has been working all along. And for me, it's
kind of a common sense approach to planning. And that's how this is the first year we've used a logic model, sort of an official logic model. We've done it before, but basically, the normal way, or the old-fashioned way maybe to do a flex program is to get a bunch of people in a room and say, well, I don't know, what do you think we ought to do? And so the logic model, and then you get a bunch of activities and you figure out if your budget supports it, and you divide them into the categories of QI, PI, and the other, and you're done. This just gives us a chance to go beyond that to saying, to lining the things up. Before you tile your bathroom, you want to dry fit it to make sure it's all going to work out. And that's to some degree the same idea here. You say, well, if we do these activities, what's that going to do? Well, we're trying to affect impact on a strategic level. We want the hospitals to have higher quality. So how are we doing that? And if we do all of these things, will the quality go up? Yes or no? One of the important aspects of the logic model that I don't think we've done yet is to make sure that you have measurements for all of the pieces. We've got the measurements, but we just haven't recorded enough data yet to make sure that it's all working. So your activities are successful, and then you measure the impact. Then you measure your strategy, like, is quality going up in hospitals or in small pieces of hospital quality? If it is, it's working. If it's not working, you need to retool. So like I said, just sort of a common sense approach, lining everything up together to make sure it's knocking all of the dominoes down. And then as far as the balanced scorecard, I would say we use sort of a bastardized version of it. We haven't done much training in it. So basically it's just a couple of years ago, we wanted to make sure that while we were busy doing a bunch of stuff, that we were actually successful as an office. So our scorecard is wider than the Flex program. It's the whole office. And so we just, we want to be able to, at the end of the day or the end of the year, feel like we have been successful. So that's at a high strategic level. It looks at things like how many physicians are we placing, how much technical assistance are we providing, and how the level of site visits. It's a lot of, on one level it's a lot of process measures or outputs, but at the same time it's how we wanted to get a sense of, are we doing our job? So the balanced scorecard just collects the data on a quarterly basis, and you can look at it in one sheet and see your greens, yellows, and reds, and see that you're hitting your targets or you're not, and then that turns around and gives you discussions on, well, why aren't we hitting our targets? So I guess that's it in a nutshell.
Yeah, that's well said, John. In essence, what we use our balanced scorecard for is when we have issues where they're either going to be problem areas for us, or they're going to be areas of opportunity for us that we can do a better job of serving our state customers, just everybody in general in that regard. And so it highlights something. It's just like we have so many things to do as flex programs. As if you're a hospital, you've got thousands of processes within your. It really brings the most important things to the surface, and it does it in kind of a balanced way, as John has said. And the good thing about it is none of us are purists here. And most of this stuff needs to be adapted from the Harvard Business School shelves or et cetera. But one of the things I like best about Balanced Scorecard is that it can evolve. It can turn into what is best for Wisconsin. There's not going to be any Balanced Scorecard Nazi watching out for you that, to slap your hands if you're doing it wrong. And the scorecard itself and that whole technology has evolved over the years from what it started out as well. So have you built this into your grant proposals, John, or is it something that you do retrospectively after you put the grant proposal out there?
So we talk about these in the grant proposal. We haven't had a competitive cycle yet, so I don't know how much traction that's going to get with reviewers. When we talk about it, we say this is how we evaluate ourselves. This is how we plan. This is where it comes from, and we're doing pretty well, based on that. So we try not to get too much into the weeds with it, but like I said, I haven't had any reviewer write back, oh, that's great, you're doing a balanced scorecard. But I like to think that our proposals are more orderly and more solid because of that information.
Yeah, good. Thanks, John. Does anybody have any questions before we move on to the next section? Any questions? Anybody want to share something that they're doing that they really think works great? Again, part of what we're trying to do is to get some commonality in terms of an approach. So we can all learn from each other on this. Anybody have any questions or want to highlight a framework that they've been using? Okay, I'm going to turn it over to Tracy for part two here.
I do know, just I was thinking, Elisa Dresba in New Hampshire just started using Logic Model recently, and I've had some conversations with her, and actually we were hoping she could join us today too, but she had a conflict. But I know that she was hesitant about it, I think, and I'm recalling from our conversation a little bit just about the time commitment up front to sit down and do the Logic Model, but afterwards she did a Logic Model for each core area of the Flex program separately, so she did 3 different ones. She didn't do anything on converting to CH status, but she was so excited when I talked to her about the time that she did and that it really helped her kind of weed out what they didn't need to be spending resources on and things like that, or where they were maybe spending too many resources. And I think it's just a nice example of somebody that Elisa is just a one-person shop right now for Flex. She's the only staff member that they currently have. It's just a nice example of somebody being able to take the time and do that, or make the time and do that, and really had a better picture then of where they've been and where they were going because of that.
And then one last thing on this section is that TASC is here to help. If you want to venture out into this area, maybe in your next grant proposal, do talk to us. We have lots of tools and resources, and we're not quite as experienced on the Logic Model, but John Gale is referenced here. John's a great resource as well, and we certainly can help you kind of work through some of the barriers or help you jumpstart the framework. Really highly recommended to you folks, and I know that Mike has been very supportive of State Flex programs using it as well.
Actually, Mike, there's a question that I think maybe you can best address in the chat. Mary Sheridan from Idaho is asking if there will be room in the FY13 Flex grant application to include Logic Models.
Remember, it's *# Mike, if you're there.
Yeah, I'm a little slower with my BlackBerry. So in general, you can incorporate it, but it's not a mandatory requirement for the Flex NCC. So if you want to show how it relates in the narrative and from there on how you're incorporating it towards activities, you're welcome to, but it's not a requirement. It's just more for you to think of how you're going to outline your processes.
But I'm sorry, Mike, this is Mary. But is there some place that we can actually put it in the application if we develop one?
At this point, no. There's not a way I can insert it unless you put it in as a separate attachment that goes along with either your progress report narrative or one of your matrices. There are page limit requirements here, so there's only a limited amount of space. It depends on how you frame the rest of your your application, basically. So
Okay.
you can insert it, but just make sure you notate it, but there won't be an attachment space for it.
Okay, thanks.
Great, thanks, Mike. Thank you, Mary, for the question, too. So I think what we heard both John and Dave say is that frameworks are really can assist in mapping where you want to go, and they can also help kind of review where you currently are or where you've been to. But first, what you need to do is actually document the outputs of activities and the outcomes of the objectives that relate to those activities. So now we're going to spend some time talking about the difference between outputs and outcomes, and then some examples of documenting outputs and driving outcomes with the work that's been going on with some of the state flex programs. So these next few definitions that I'm taking directly from the soon-to-be-released evaluation toolkit, and I'm actually just going to read the slides because I want to make sure not to mince this up a little bit. So an output is the direct product of program activities. It's the tangible results from the completion of activities or initiatives that support the project objectives. So an example of an output is the amount of technical assistance provided to the critical access hospitals, or that you held an ICD-10 workshop. Outputs are what you did, and they are not what happened as the result of what you did. So just a general example, outputs are the widget made in the widget factory. They're not the changes as the result of the widgets. An outcome is the result of the program operations or activities, or the effects that are triggered by the program. An outcome is changes or benefits to individuals, groups, organizations, and or communities that result from program outputs. So examples of outcomes are, after attending an ICD-10 workshop, 6 hospitals implemented a comprehensive plan to transition from ICD-9 to ICD-10. So with the widget factory example, outcomes are what happens as a result of the widget, not the widget itself. The widget itself would be the output. Another nice analogy that we talk about here a lot at the center, especially in terms of our balanced scorecard too, we talk about this a lot, is from Terry, and that's about the bird flapping its wings. So an output is how many times the bird flaps its wings. The outcome is the distance that that bird travels. So a bird could flap its wings 100 times and go 2 feet, or a different bird could flap its wings 100 times and go 20 feet. And that distance would be the outcome, but the output would be that measure of the number of flaps.
Yeah, this is something that I got in my graduate school years and years ago, and I never forgot it, and it's always helped me, the difference. It's how many times the bird flaps his wings is the output, and the distance the bird flies is the outcomes. And sometimes visuals, we're trying to incorporate, you're going to find in TASC, we're going to try to get more pictures up here, more things that can help, rather than just tons of words. This picture always was important for me to understand the difference.
So what we're going to talk about now is just some examples from the FLEX program coordinators and directors about specific tools or methods that they've used to track and document outputs and measurable outcomes in particular projects that they're doing. So I know that Carol Bischoff is on the line, and Carol is the FLEX director for the Montana FLEX program. Carol's been doing a project for the last few years with one of the universities in Montana on lead rapid improvement projects. And so they've been really able to have built-in measures and documented outcomes through that lean process. Carol, if you're on, could you tell us a little bit about that project and how you go about documenting the outputs and then rolling them into outcomes?
Sure. Can you hear me?
Yes.
Okay, great. So yeah, like Tracy said, we've been doing this project now with the Montana State for about 3 or 4 years, and the beauty is in its simplicity. Very, very easy. It's a quick, at the request of the critical access hospital administrators, they wanted something that was quick, easy, with a good return on a very little investment. So I think we've accomplished that in in that we have a very well framed application where we ask the hospitals to identify 2 small problems. I know lean can be a big culture change in a hospital, but we have sort of a simplified approach that has been real successful to make day-to-day life in our hospitals quite a bit more pleasant. So, for example, one hospital said they wanted to decrease the, what was the term they used? Let me just see it here. Decrease the non-value added time in their dietary department, and they wanted to lower it to less than 15%. And so when we start the project with the lean students, we clearly define what it is the students are supposed to do. So in this case, they did a job. They looked at each employee and what they did with their day in the dietary department. So by job type, hours spent doing different duties. And they just did a time study, actually. Their major problem then that they identified once they were on site, so they had the data. They had a problem. They had some data. Their goal statement then was to decrease the amount of gratuitous time, as I said, to less than 15%. So after they did, I don't know, those of you that are familiar with lean know that they go through many different, they have many different tools, and they do an A3, and they do all these other steps. So in the end, they came up with they actually eliminated one whole position, which the person did not lose their job. They actually were replaced in a different part of the hospital. But they lowered their non-gratuitous time to less than 10%. So I think that was a very successful, again, this is a 2-week project. So it goes very, very quickly, and I think, as others have stated earlier, it's always sort of that idea that they know at the beginning, they have a clear idea of what their end goal is, and then they go through steps to achieve that goal. And I think now we've never had to really report our lean work as a consolidation in the past. I've always been able to report through my flex work what's happened with each project. So this year we're actually building in some sort of standards for the project overall, and we're just now getting applications in, so we're starting our process for this year, so I'm not sure how that will go. And then just if you're curious, the estimated cost savings for the look at making that workflow in the dietary department more efficient was approximately $8,000 a year. So, that's substantial for a small hospital. But I think what I've been able to do in applying what I've learned through my exposure to lean is to look at that end goal. What is it that we really want to accomplish? And then from there, kind of like what John said with the logic model, from there, how do I want to accomplish it? So, I set my outputs and my outcomes, based on that. So just a quick example on that is that, for example, our clinical improvement studies, which is something we do here in Montana. It's a small group projects around improving clinical care in hospitals. So my outputs, again, what we wanted to do was make sure that we had 2 studies going at all times, and that we have a benchmark set for the number of hospitals that will participate, and then the number of hospitals that will show improvement. So in a specific area. So that was my outcome, and then we kind of worked sort of backwards from there, tracking how many hospitals showed improvement, and then actually implemented evidence-based protocols. So, I've been able, because of what we've been doing with lean, I've been able to translate that into how I write my various activities within my work plan.
That's great, Carol. Thanks for explaining that. I think one of the nice things, too, that you're doing with the lean work is that you're relying on others to document the information for you. And I know that that's something that many flex programs struggle with, is just different ways to get the information that they need. And either if it's through students during a particular project, and lean does have those nice measurable outputs and outcomes, or even a contractor providing project for you, is asking them as part of the deliverable to document the information for you that you're asking them to do. It just saves you an extra step as well. But I think that those are two great examples of documenting the outputs and outcomes, and I think that training example is a nice one too. Of you're keeping track of how many are attending a session and looking on later to see what's actually happening by them actually attending that session. Catherine Miller, the program manager with the Wisconsin Office of Rural Health, has a similar example to actually share with us, but a care transitions workshop that they've been doing, and also another example about a QI Director Leadership Program. So I'd like to ask Catherine if she could share those two different examples too with us today.
Yeah, happy to. Can you hear me all right?
Yes, thank you.
Okay. So I wanted to bring you two examples because we do a fair amount of contracting, subcontracting in our office for particular projects. But I wanted to give you an example of one that is a subcontract and one that isn't, and kind of what the differences are in tracking there. So we have done some regional training around care transitions where we divided up the state into 4 kind of quadrants and brought folks together to talk about care transitions in their section of the state. So what we chose for measures for that, number of attendees is an obvious one, and the percent of critical access hospitals attending. So out of our 58 critical access hospitals, what percentage attended? And we were tracking that for each region of the state, so 4 trainings in total. So the outcome, and I like Terry's bird example, that makes a lot of sense to me. I often think of outcomes as the so what to what you're doing. And so, so what that we're providing care transition trainings, what does that mean? And so what we put for an outcome is that readmission rates would improve. So how we did that is we tracked with the attendees what their readmission rates were before they attended and what they are after. Now, I don't have any of the afters recorded at this point because of the data being behind. We have to wait till that new data comes in. So it's not perfectly scientific, but, and obviously we can't say that because they went to this training that was, had everything to do with their readmission rates improving, but we'd like to think it was part of it. So the second example has to do with a leadership support program that we're doing. This is an example of something we subcontract out to the Rural Wisconsin Health Co-op. We do a lot of initiatives jointly with them. So this targets new quality folks in critical access hospitals, which we define as being in their role 2 years or less. And we had found out early on that there's quite a bit of turnover in the quality professionals in the hospitals for whatever reason. So we wanted to target a program that would help the ones that are new to their role. So we provide them with a toolkit, kind of a mentor from another hospital, and then they're able to attend some education, almost like well, they call them round tables, almost like a support group, you could say, where they can bounce ideas off of each other. So what we did there for outputs is to track the number of people that are eligible for this. So looking at all of the 58, how many of those had someone new in their role of 2 years or less? And then out of that, what percentage signed up? So if we had 20 and 10 signed up, for example. So then looking at the outcome, it was kind of a bit of a self-evaluation. Our subcontractor developed a pre and post type of survey where they pretty much would self-evaluate how they feel they're doing in their role. And afterwards, did they feel that they're now better equipped to handle their role of quality in their hospital? So pretty much a self-evaluation tool to get at that. So what's nice about subcontracting is, as Tracy just said, you can ask the subcontractor for those deliverables and say, here's what we expect of you, here's what we want the output and the outcome to be. and then those are fed to me in quarterly reports, and then I can enter them here into, believe you me, giant Excel spreadsheet where I try to make every attempt to track all of the projects. Anything else I can tell you, Tracy?
I think that those are good examples, Catherine. You know, the one you were just talking about with the leadership program is a good example of, you know, listing your speakers to tell you, you know, and help you develop kind of the learning objectives ahead of time, and then looking at some behavioral change from a training workshop. And then again, like you just mentioned, you know, having those contractors, the consultants, kind of help you do the work that you're paying them to do too, and give you those numbers. And then the first example you mentioned with the care transitions workshop, with being able to access that readmission rate, you're relying on a system or a tool that's already there for you, that's already capturing data, and you're just linking some of your activities that you're doing to some data that's already being captured and looking for impact there. And I think that's a nice example too.
Yeah, that's a good point. I didn't mention that as far as the care transitions and the readmission rates. We have the benefit of being able to use our hospital association has a huge data repository and kind of benchmarking tool called Checkpoint. And so that's available for us to go on, and all of our hospitals submit data to that. They may not submit everything, but they're submitting to some extent, which is also attributes to our high hospital compare participation in our state. So we're able to go on there, and you know, the data's not to date, you know, it's behind a little bit. So as I said, going on there before and then waiting until data would reflect that they've now attended the workshop and what happened.
Just another good example, I think, we see in North Carolina, and just following up on some of the comments about Lean, one of the things I like best about Lean, it's so incredibly outcomes-oriented, and that, in fact, it's so much about outcomes, but that the hospitals themselves do the heavy lifting and the work on this. In other words, they start out and they document how much time they're spending, how much money they're spending, et cetera. And then after the Lean training and after the Lean work, they document how much money they saved, how much time they saved, et cetera. It's all very, very outcome-oriented. And I know that North Carolina, with the help of both the Flex program and some funding they got from the Duke Foundation, was able to document, I think, on average, like $700,000 savings on average, for every one of the critical access hospitals, the rural hospitals, I guess it was, in their cohort. Lean doesn't make a difference. It does produce savings of time, resources, et cetera, and it's very quantifiable just because of the methodology itself, and easy to measure and easy to report back.
Great. So, you know, I think what we talked a little bit about with the various different speakers is kind of continuously building and testing and adapting tools to help us document outputs and outcomes, and thinking creatively about where we want to be with the outcomes, and how to build those activities to get there, what resources might already exist either within our own organizations or partner organizations or contractual relationships. And then also, you know, thinking about the outcome, how far do we want to fly, and then how many times do we need to flap our wings to get to where we want to be. And, you know, there's never the one-size-fits-all method or tool that's going to work for everybody across the board for an activity. But, you know, being able to adapt and keep changing and trying and testing things is actually really part of good project management, for continuing to review things and tweaking things. And it also lends to good program evaluation, and really the importance of a framework and a strategic plan, so you know where you want to be going and what resources you have or need to get there. And so the last thing we wanted to close out the discussion with today was Kind of thinking about multi-year activities and beyond just a one-year budget period, continuing activities from year to year, or building multi-year activities in the first place, or sometimes you just need to change course. And so Terry's going to talk to us a little bit about changing course.
Yeah, and I want to, again, promote the TASC blog. If you go on to our website, you can see a number of different entries. We're hoping that more of you will use it, that you'll feel free to come in and share your comments, your perspectives with your colleagues as well. But recently, Cap Wilkes, who's one of the managers in our organization, wrote a blog about sailing and how it actually compares to the work we're all doing in terms of performance improvement, and in her particular case, she's managing rural HIT networks and providing services to them as well. So we thought we'd kind of conclude things with thinking that you're never sure what you're going to encounter out there, and that's another reason to put a framework and set up the system of outcomes and outputs and evaluation, is that things happen. We have changes in direction. If you're sailing out here in Lake Superior on a brilliant warm day, 80 degrees, and the wind changes, the temperature can drop 40 degrees and the wind can pick up and become an incredible force. So people racing to get the sails down before they're swept overboard, or the sails basically take them in uncontrollable directions. It is just kind of capturing this longer range of where we're going. You can see through, what Catherine and John talked about. They've got a vision in Wisconsin, and I know so many of the flex programs out there as well. So we may not get the direct route. Things can happen, but we'll adjust and we'll keep moving forward. I think Dave, who's already talked a bit, I've always been impressed with what Nebraska does on their larger versions. So Dave, you want to talk again just briefly about how you've developed kind of a multi-year plan and how you adjust it periodically?
Well, I can try and do that, Terry. Sometimes things have just kind of evolved, that we thought things would start out and maybe be 1 year or maybe a little longer, and we're still doing them. And I imagine that's the case with many flex programs. You might recall a few years ago we had you up and some other folks for the balanced scorecard. That must be 8 or 10 years ago now. And I thought maybe we could get 5, 6, 7 hospitals interested, and we met after this conference, and the first we had 15 hospitals that were interested. So we knew we couldn't do all of those in 1 year. So I think that now that we've had some experience, we tend to think about more realistically how long will it take to really be able to deliver this type of service. And we usually conclude that that we're going to have a fair number. Of course, we have 65 critical access hospitals, and we usually think that we're going to have anywhere from 30 to 40 at least that will participate. So we try to, one of the things we always try and do is to develop expertise within the state. Sometimes that takes a little longer to do, and thus that leads to multi-year budgets as well. For example, on lean training and lean, the lean project, we found that the learning curve was really fairly steep for our hospitals, and that it would take a little while before they could really be doing doing projects where we could get meaningful outcomes. I think we've now achieved that, but we're also trying to expand that to other hospitals, and thus we're thinking differently about how we do the training and provide technical assistance. So I think that one of the lessons that we've learned, at least, is that we need to think about more than 1 year when we start a project. We might do a training or something like that over a single year, but normally within our Baldrige framework and within our thinking that we're usually thinking multi-year. Now, sometimes it's difficult to know when you've reached the point where you no longer need